Good afternoon, good morning, and good evening to everybody joining us from around the world today. Thank you for joining in for the webinar. My name is Alex McFedrin, and I work with the Polio team at UNICEF HQ. Today, our theme of webinar is the Standard Operating Procedures, the SOPs, for Polio Outbreak Response and Preparedness. Today we have two presenters, Anindya Bose, Health Specialist, and Sahar Higazi, Communication for Development Specialist, both from UNICEF HQ. As we get ready to begin, please just make sure your audio is muted. Apologies if there are some technical issues, but it will really help us to keep everyone muted so that we have good sound recording. As well, we'll take questions and answers after the presentation, so if you have questions throughout, please just jot them down to yourself. And then at the end, we'll ask you to use the instant messaging, which is on the left-hand side. You may have seen some messages from the beginning going back and forth between people. Please refrain from using that throughout the presentation and just use that at the end when we open questions and answers. If you do have technical issues, though, you can write a message there, and I will try to assist. But otherwise, let's get underway. So today, the contents we have are based into two parts. The first part is presented by Anindya. He will go over the introduction to the SOPs, the difference between an event or outbreak, vaccine-derived poliovirus classifications, and risk assessment and grading. Followed by this, Sahar will present part two, which will be strategies for rapidly interrupting an event or outbreak, Global Polio Eradication Initiative critical functions, and the UNICEF areas of accountability to the polio program, as well as just a small briefing on the role of Team B in terms of the SOPs. I'm now going to turn it over to Anindya in New York, and he will be presenting, as I said, on the first part, and we'll take questions at the very end. So go ahead, Anindya, when you receive control. Thank you.
Good. Thank you, Alex, and I hope everybody can hear me. And thanks everybody for joining in. I'm really impressed by the great turnout today, and I hope this session would be useful. So before we move over to the couple of slides, I would just like everybody to just take a step back and think what an outbreak is in the context of polio. As you know, the world is almost entirely free of the wild poliovirus today. We have endemic transmission only in Afghanistan and Pakistan. So the rest of the countries that have been polio-free for many, many years, many countries, and even the most recent, say in the African region, these countries have been polio-free for more than a year now. So any red dot on the map that comes out signifying a wild poliovirus or even a vaccine-derived poliovirus would signify an outbreak in those countries. Now, when that happens, again, without getting into the nitty-gritty of the SOP, just think through this, that these countries are not prepared. They're not doing polio eradication activities all the year round because they have been polio-free. Say a country like Myanmar or Nepal, they have been free for so many years, and suddenly something pops up, so they're caught unawares. GPEI is also caught unawares, unprepared. So therefore, earlier outbreak response tended to be a little haphazard, and GPEI, the Global Polio Eradication Initiative, wanted to stop that, and therefore we designed certain standard operating procedures so that all partners are on the same page, national governments are on the same page, and we deliver certain products to respond to the outbreak in time within a defined time frame. So with that, let me get to the next slide. Shall I? Thanks. So I believe everyone is on slide 4 now, which talks about, does this mean anything? Okay.
Go ahead. You can.
Okay, yeah, thank you. So we have, which talks about the introduction to the SOPs, which I just gave you. I mean, that is the background to the SOPs. The standard operating procedures, remember, these are for mid-2016 to mid-2017. We have a validity period, and by that time, again, the program changes. So we will review and revise the standard operating procedures. But for now, what I'm talking about now is valid as of today and likely to remain valid until mid-2017. There are two parts. I will not get into details of SOPs. There are separate, very much more detailed workshops on that. But just to give you all a broad conceptual framework, there are two parts of this standard operating procedures. Part one, any poliovirus outbreak. It could be wild poliovirus, type 1 or type 3, or vaccine-derived poliovirus, type 1 and type 3. Part 2 specifically responds to type 2 poliovirus outbreaks. It is very unlikely to be wild, and I'll explain that why I'm saying it is unlikely, but it could be from a vaccine-derived type 2 poliovirus. And while part 2 of the standard operating procedure basically builds on what is there in part 1. So part 1 has timelines, the type of responses, etc. The vaccine to be used will generally be bivalent OPV in the part 1 of general SOP, responding to type 1 and 3 polioviruses. But when you come to part 2, now all of us, let me remind all of ourselves that in April, May 2016, we did a global TOPV to BOPV switch. That means that we are no longer using trivalent OPV, which contains type 2, trivalent oral polio vaccine, which contains type 2 Syrian virus inside it. So any type 2 that comes up will need a special vaccination response by monovalent OPV2, and that has its own challenges and own operational procedures. So therefore, the part 2 is different from part 1. So because there's a different operational protocols to be followed, there are common principles as well as there are some additional things that needs to be done. I'm not reading through the slides. I hope all of you can see that. And all the details are there in the links in the last slide, and you can access those standard operating procedures and go through that. We are on slide 5 now, which explains, again, takes a broad sort of a 30,000 feet level view and why the outbreak standard operating procedures. This, as I said, ensures that the full strength of the GPEI partners and proven strategies are available to support polio-free countries, and ensures a common understanding of the critical actions, because in the Global Polio Eradication Initiative does not stand alone. There are the partners, WHO, UNICEF, CDC, Rotary, and Gates Foundation. Definitely they're there, plus national governments, who are a key component for success of any global program. So all of them are on the same page because all of them will refer to these common outbreak SOPs. And it naturally documents the roles and responsibilities of GPEI partners and provides a standard against which outbreak response can be assessed. Like we say that in an outbreak, you need to sort of classify the outbreak, grade the outbreak within 24 hours of confirmation. Within 14 days, you need to put in your first SIA response. And within 120 days, that's about 4 months from confirmation, you need to interrupt the transmission. These are all ideal, and this is what should happen. If we cannot do this, we are failing behind the milestones set out in the standard operating procedures. So there are several others. I just mentioned the key ones. So that is where we mark ourselves, we evaluate ourselves, and that is the whole purpose of the standard operating procedures. On slide 6, at every wild or vaccine-derived poliovirus confirmation, we have to ascertain whether this is just an event, that means not associated with circulation, or this is an outbreak, which means that this virus is associated with circulation, person-to-person spread. Now, there are certain broad parameters. Of course, the final call is taken on a case-to-case basis, but for broad parameters to understand whether it's an event or an outbreak, let us first try to define what an event is. The event is a single poliovirus isolate without evidence of circulation. That means it could be a vaccine-derived poliovirus in a person or an environmental sample. That means a child could have been paralyzed and from a vaccine-derived poliovirus, or it could have been isolated from an environmental sample, or it could also be a wild poliovirus, not in a child or in a case, but in the environmental sample. And this has to occur in a non-endemic country that has been polio-free for at least 6 months. You see, in an endemic country, another wild poliovirus pops up, that does not constitute an outbreak because they're already having endemic transmission. So what are the implications of such an event? The implications is We are not definite, but this could be a probable or possible ongoing transmission, but we are not definite at this stage. Therefore, we are calling it an event. And there's a medium to low risk of further transmission. If that is an event, then what really is an outbreak? You see, an outbreak is a wild poliovirus or circulating VDPV. Note that we have put a prefix here with a C. So let's first take up the wild poliovirus. You see, if wild poliovirus is isolated from a person, no matter whether we find secondary cases or not, it constitutes an outbreak. There are no two thoughts about that. If we find a vaccine-derived poliovirus where we have evidence of circulation, even from one single person, we take it as an outbreak. I'll give you an example a little later how we have done that. Wild poliovirus or genetically linked vaccine-derived poliovirus in greater than one environmental surveillance site. ES stands for environmental surveillance site with separate catchment areas. All this is a little difficult, but let me give you just one example to establish that. We had isolated a vaccine-derived poliovirus in Nigeria, one sample from one environmental site. Now, if you went back to your previous slide, that would be an event. But this virus that we isolated in Nigeria about a couple of months back was genetically linked to an older virus also isolated from Nigeria. So that told us this virus had been transmitting in Nigeria, although this was a single environmental sample, it had been transmitting in Nigeria. Therefore, we labeled this single isolation as an outbreak and not as an event. So even one virus, if genetically linked to other viruses, will be labeled as an outbreak. For wild poliovirus, as I said earlier, from a case is always an outbreak. The implications of this is we have now confirmed that there is ongoing transmission and there is a high risk of further transmission. Vaccine-derived, we have been mentioning this term. So what is a vaccine-derived poliovirus? You see, oral polio vaccine contains weakened but live polioviruses. They are so weakened that they produce immunity, but they do not transmit from person to person. Now, every living agent, because these are live viruses, they multiply within the body, and in that process, they also change a little bit. Their RNA changes inside the virus, so that is mutation. Sometimes the change is such that they acquire properties tending towards wild virus. That means they acquire the property of transmitting from person to person. Now, two things remember, that this is, first of all, very, very rare. Second, this can only happen in an under-immunized population. It never happens in a well-immunized population. So a vaccine-derived poliovirus which has started transmitting from person to person tells me two things. That one is it's of course very rare, and the second is that it's a very okay. Thank you. So the other is that we have it's an under-immunized population. There are the classes of VDPV which are explained there. I'll not go into details. Only just the immunodeficient related VDPV is in a person who has internal immunodeficiencies, for which reason he or she cannot clear a live virus from his or her system. Next slide. Okay. Now, this is once these are outbreak or events are classified, we have a grading system, and grading system is fairly intuitive and simple to understand. If you find it's a sort of a bi-category matrix where the capacity, country response capacity is graded as strong, moderate, weak, and the risk of the virus transmission is graded as low, medium, and high. And you have, and certain combinations are grade 1 outbreak, certain combinations grade 2, and grade 3 are, of course, the classic example when a country has a response capacity as weak and a risk of transmission as very high. There are several countries which you'll know perhaps through your own work in different regions where this can happen. Equally, there are several countries where there is a strong response capacity as well as the weak, as well as the risk of transmission is low because of high population immunity. So we grade this because the grading decides on the scale of response that GPEI mounts. So that, I believe, is there anything else? Okay. Thank you. I'm sorry if I've overstayed my limit by a couple of minutes. So thank you, everyone, for attention.
Okay.
So as an India has overviewed in terms of the specifics, parameters that would take us to confirm that there is an event or an outbreak in a given country, what would be the possible measures that could be taken to ensure that we can rapidly interrupt an event or an outbreak? There are 5 specific areas that are highlighted in the SOP. The first one is the full engagement of governments in the outbreak response. And by that, the SOP details specifically the importance of the declaration of a public health emergency of international concern, especially if it's in a country of high risk, as well as the full implementations of different requirements specified under the IHR. The second important area of strategies is the risk assessment and outbreak zones. And usually when the virus is detected, whether in the environment or in a case, it is specifically or usually in an area. In many situations, it's identified before as a high-risk area. And this becomes the focus of the interventions. And therefore, any activities would be within this area or around the catchment area where the virus was detected and becomes the focus of the strategies. So if this is a remote area, there has to be strategies taking into account to ensure that all the children are captured, as well as if it's in an IDP or refugee camps or anything of a kind. The third strategy for interruption is the effective communication and social mobilization. And classically, this is very much UNICEF area, but it starts initially with undertaking social mapping of vaccine hesitancy and community influencers jointly. It's important in this phase at the very beginning that we know exactly what are the epidemiological as well as the social context and the situation, so that we are in the best position to be able to design the best interventions to reach all the children in these areas. As well, in this context, we would need to have a full audience profile and immunization practices. We would need to make sure that the capacity of the health workers is strengthened and they are able to attend as quickly to implement quality campaigns. We would need to ensure the engagement of influencers, as well as making sure that all the communication, social mobilization activities are fully integrated into the micro plans. And once campaign starts, it's very important that we ensure that all relevant social questions that will give an indication of the effectiveness of the strategies are integrated as part of the independent monitoring forums and for any follow-up, so that no child is being missed. The fourth strategy is implementing a robust immunization response. As India mentioned, the first campaign comes within 14 days. So this means that all the things I just mentioned would have happened in the first 2 weeks. And that also implies that the first campaign would go up to 2 million children. And the age of the children is pretty much defined according to the risk factors that also India had earlier specified. In some situations, there could be among the strategies the need to implement short intervals, SIAs. But the most important point is always paying attention to the population that are at high risk, refugees, IDPs, migrants, all kinds, so that most importantly we ensure high quality campaigns and that no child is being missed. The last strategy is on the enhancement of AFP and laboratory surveillance, and I will not go into details of that in the interest of time, but all the details are already mentioned in the SOPs as well as in the slides. So what are the critical GPEI functions? There are 6 areas specified in the SOPs, and those include from the minute of the outbreak confirmation and grading referred to earlier, to the coordination and advocacy, the technical support, information management, logistics, finance, and the external communication and social mobilization. For us in UNICEF, what is important is to have a bit of a zoom in on the areas specified in the SOP that are of accountability to UNICEF. And these are classically the communication, social mobilization for demand generation, as well as the vaccine supply and management. And these two are important in terms of our contribution to the total GPEI initiatives to interrupt any outbreak. So let's look at the circle of events of how things happen if we have an outbreak or an event response by time. From the minute we have the confirmation up until 72 hours, the most important thing to happen upon the confirmation of the event and the reported case, is to have clear identification of the focal points at regional, at headquarters, and at country level. And as I just mentioned, to have the joint UNICEF-WHO epidemiological and social case investigation, because that's the most important point to give us light on the case, to understand the context, and to know exactly how we will proceed. There are standard templates and forms to undertake these investigations, and we will later refer you to that. The second important point of time is during the first 2 weeks. And this is the time when what we call Team A, who is a staff member, arrive into the country to support the country team to start looking at the national plan, ensure that the social and epidemiological investigation has been done, look at vaccine and HR needs, and also start thinking of the initiation of the response towards having the first campaign within 14 days. The third key point is between 2 weeks and 3 months. And this is when we would have implemented most of the campaigns, and we would have had the remainders of campaigns being planned. Monitoring had been already conducted for at least 2 or 3 campaigns, so we would know exactly what are the specific points of bottlenecks or weaknesses that should be addressed in that situation. And that leads us to the next important timeline, which is 3 months assessment, or what we call the OBRA. And the outbreak risk assessments gives us an indication of if the country is on track or not, are they progressing towards the interruption or not, and what are the extra measures that need to be taken correctively to ensure that we go back on time. Moving on, by the 6 months, a second OBRA is organized by external teams who are usually outside to the program, who can give a more of a critical eye to what is working and what is not working. And in that situation, there are usually expectations that the virus would have been stopped in terms of circulation, and if not, there will be very specific recommendations on how this should happen. Larger attention goes back to routine immunization strengthening, and if things are on track, we ensure that we maintain the successes that have been done. And last but not least, we move into the closure of the outbreak, and this is where there are additional expectations toward additional activities for strengthening of routine immunization, any additional preparedness and maintenance of the efforts done. So in the interest of this presentation and review of the SOPs, let's have a bit of a zoom in on the management of the outbreaks. And there are usually 2 critical teams who are involved in a management of outbreak or an event. The first team who are deployed is Team A, and this is deployed for a period between the 72 hours until 1 month. And in that situation, he or she is a staff member who are immediately moved to the country of concern, work with the country team, as I just mentioned, to put the plan in place, ensure that all the initial measures are ready to be launched. The Team A person hands to a Team B, who is deployed within a period of 1 month to 6 months, and this is normally a consultant who is deployed to the country, work with the team on a longer term basis to ensure that all campaigns and activities that are planned are implemented up to the quality that is required. As mentioned, C4D remains the area of focus. Should it be needed, we can also deploy health, immunization, or vaccine, more expertise as per the need. As mentioned earlier, we have referred to several tools, whether the SOP, the guidelines, or some of the tools that we have been mentioning through the webinar. And these could be all accessed through the Rhizome, which is an interactive website that takes you through all the polio resources and all the polio materials on different aspects as relevant to the SOP or otherwise. And in addition to this, there is always the global website for polio eradication, where you can find all the relevant GPEI materials on this one. And at this point, I would leave it back to Alex. Thank you very much.
Thank you, Sahar. So we'd like to just let you know before we go into the question and answer some of the upcoming dates for other webinars. That will be Thursday, October 6th, Thursday, October 20th, and Monday, November 14th. We'll focus on key areas of the polio outbreak and response, such as Team B deployment, logistics, and the polio communication global guide, among other themes. If you have any questions about that, you can, of course, email me, and you will receive the newsletter and other invitations as necessary. We'll now move into the question and answer. Please type your question using the messaging tool instead of speaking, just so we don't interrupt each other. And I ask if you can, please feel free to start doing that now. If you know who you want to direct your question to, if it was more part of part 1 within India or part 2 with Sahar, you can type in their name in the question in the side, and then we'll take questions in groups. So if you have any questions, this is your chance to ask the experts. So please feel free to ask them now. Great, thank you for the first questions. We have questions from Mikonen and also from a guest, sorry I'm not sure on your name, specifically about the timelines for Team B. Just so you know, we will be doing a particular webinar specific to Team B deployment and logistics on October 6th, and that will be with myself, Alex, and Jen Gatto. So these questions will be answered in depth there. Do you have anything to add, Sahar?
The important point for Team B for us is that they should be on the same equal foot as Team A. And that's why this webinar is open for both internal UNICEF colleagues as well as our external colleagues on consultants roster, whether they are C4D or vaccine and CCL management. And what I'm saying is that there is also a process for the transition between Team A and Team B. So that's why it's very important that both have the full understanding of the same things in terms of their TORs, in terms of how the plan should be managed, the different timelines in the process, and so on and so forth. So additional to that will probably come on the next webinars, but if you have any specific questions with regard to the role of Team B, we'll be happy to take that forward. Thank you.
We have a question from Alejandro. What will be our response to certain outbreak with the current BOPV shortage? I'll pass this over to India if you want to respond to this question.
The question is regarding the current BOPV shortage. Let me assure everyone that for the response rounds, Global Polio GPEI has reorganized some SIA campaigns in some countries, and we are adequately resourced for the current response rounds, including the additional round until the end of in Nigeria and the surrounding countries. So that has been taken care of. Additionally, UNICEF Supply Division is also trying to secure additional doses of BOPV, but you will understand because of manufacturing processes, this will take a longer time, and we are looking at the first quarter of Q1 2017 when additional doses can perhaps be secured. And so that's all taken in a nutshell, that's all taken care of to respond. Over.
Okay, I have another question for you, and India, hopefully you can answer from Hussein. He says that Somalia became polio-free for more than 2 years. However, there are about 200,000 people who've never been vaccinated with OPV due to security issues. Is there any scope for environmental surveillance to see if there's any circulation in these inaccessible areas?
Well, yes, it's a very, very good question, but let me mention a couple of points. First of all, we know this from smallpox eradication as well as in polio eradication, that while it is absolutely important to immunize each and every child or the target population with the appropriate vaccine, eradication does not necessarily mean that to achieve eradication, before achieving eradication, each and every child has to be vaccinated. In the sense, I'm not saying it in the programmatic sense. You'll understand from herd immunity that you can still interrupt transmission, as has happened in Somalia, despite a few 100,000 kids not being vaccinated because of reasons beyond GPEI control. That said, the environmental surveillance issue is very, very pertinent. At the same time, you'll understand that environmental surveillance only works where you have an opportunity of a sewage system where you have a common collection point where you can get the viral load. In the context of Somalia, I'm not aware that whether that system will operate, as we are doing, say, in India, Afghanistan, Pakistan, Nigeria, several other countries. Egypt environmental surveillance, because where we are doing it where there are existing sewage systems, where there's a drainage point for the environmental isolation of the virus. Whether that would obtain in Somalia at what status, we do not know this at this stage, but all this is being explored. there's a separate task force on environmental surveillance. So that is working out the details, how to expand as we reach closer and closer to eradication, how that's being worked out. Over.
Thank you, and India. I just have one more question for you before we turn it over to Sahar. So the question for you and India is, there has also been a shortage of IPV. What is the way forward? That's from Jamima. Over to you and India.
Thank you. The IPV shortage is very, very real, and it cannot be. There are only a limited number of countries that manufacture and limited number of manufacturers that manufacture IPV. Two ways this is being mitigated. One is, and you are also aware that all the countries that were not using IPV post-switch, they are gradually transitioning to at least one dose of IPV, of intramuscular IPV. Now, there has been a different approach to administer IPV, which is called fractional dose IPV or FIPV, which is intradermal dosing of 1/5 the usual intramuscular dose. The usual is 0.5 ml in intramuscular, and you give 0.1 ml intradermally. For routine immunization, what is being recommended that you give 2 doses of intradermal instead of 1 dose of intramuscular. That way, you still only need 0.2 ml per child instead of 0.5 ml intramuscular. Secondly, in the event of an outbreak response where you may need to use IPV, particularly CVD-PV2 type response, there's a standard guidance from Strategy Committee of GPEI that outbreak response will be only with 1 dose of fractional IPV, which increases your reach 5 times, because you're using 5 times as less amount or quantity of vaccine. So these are the 2 ways that we have approached this problem with fractional IPV and routine. Say, for instance, India. In the northern states, India is doing IM IPV because the northern state, the capacity of the health workers is relatively lower, whereas in the southern states of India, where the capacity is higher, they're using 2 dose fractional dose IPV. So that's in routine, and in outbreak, we are doing standard fractional dose only. This is in the interim. As we move towards 2017, we hope that the supply situation will improve, and then we can reconsider. But this reconsideration does not mean the fractional dose is any worse than the intramuscular dose. No, that has been proved, and there's a recent 2016 vaccine position paper which you can consult. So these are the ways that we are mitigating that. Over.
We have a couple questions for Sahar. The first one is, what are the critical issues that arise between doctors and C4D persons in polio outbreaks? That's from Sahid.
Thank you very much. That's a very interesting question, because usually in many contexts, when we have an active medical professional communities, there can be indeed several issues that arise. Whether if the situation is more controlled by private practitioners, or even with a strong health system where you don't have, for example, that high trust in the concepts of campaigns or in OPV for countries that had already eradicated polio for very long. And just to give you 2 quick examples, from Ukraine last year, for example, we had the same situation where the public practitioners and in general, most of the health cadres who have not been using OPV for too long, and the law does not allow the administration of OPV directly without a minimum of 1 IPV dose. It did create lots of C4D issues in terms of convincing, bringing on board those health practitioners, but most importantly was also working in somehow, not directly on the legislation, but which was not possible in a course of outbreak, but working more on the type of administrative guidelines that can be issued within the Ministry of Health as one aspect. The other aspect was with working with more of the senior academicians and pediatricians who are highly trusted in the country in order to reassure the medical community in general about the value and the importance and urgency of organizing campaigns using OPV. So that was one context in an outbreak, which at the end, it worked. It created the desired coverage in general, in spite of all the limitations and the challenges we faced. In another context where immunization campaigns were organized using OPV, but there was a very, very low trust in any kind of a public administered campaigns, like in the case of Lebanon, be it a middle income country where most of the parents, they seek their medical care for their children through private practitioners. There had to be a direct engagement with the private practitioners, and there were lots of advocacy work that was primarily targeting this group and working directly with them in order to ensure that any of the C4D or social mobilization or public campaigning would have any value added. So that's on this question, and I believe there was another question that was probably relevant to activities that are done in Somalia, specifically targeting high-risk areas and NIDs. As you know, as per the GPEI general way of how we are organizing the activities as well as the outbreak response, there are two categories for C4D activities. There is one category that is rightly, as mentioned, around the campaigns, whereby social mobilization activities are done before the campaigns, during the campaigns. But there is also another cluster of activities which we encourage, especially high-risk countries, to continue working and doing intra-campaigns, in between the campaigns. And part of the next webinars, one of the next webinars would be describing different strategies in details by phases of outbreaks. So at the beginning of outbreaks, for different campaigns, what can you do? If the outbreak is taking way too long, how can we manage that from a C4D perspective? Once the outbreak is under control, what kind of maintenance activities can be done? So to answer the question from an HQ level, there is definitely a very strong emphasis and stress that it should not be a one-shot or a mass media or a pre-packaged or pre-done kind of interventions. That's why we emphasize very much the importance of data and the joint investigation, so both EPI and social are together in guiding the actual interventions to be implemented.
Thank you, Sahar. We have another question from Laura. She asks, do the SOPs offer any specific monitoring guidelines and tools so that social data is integrated in the overall SIAs? Monitoring and independent monitoring managed by WHO, and in specific in Wakaro, the West Africa region. Sahar, do you want to take that one?
Yeah, the short answer, Laura, is yes. Indeed, there are very clear guidelines on that. We are quite conscious of the fact that they are not being implemented consistently and systematically in every region by WHO, and we are from UNICEF HQ level through different task teams working and pushing this issue. We are also conscious that the social epidemiological joint investigation, although there is a global tool and guidelines for that, is not consistently and systematically implemented according to the guidelines. And that's why we encourage our UNICEF colleagues to be aware of the tools, to challenge the situation when it doesn't happen, that this is the global measures. According to the SOP, it's explicitly mentioned, and that you can always take the tool and go back and implement it as per the guidelines. The other point regarding the independent monitoring, again, there is global independent monitoring template that includes very specifically social indicators that link to the original social indicators that go under investigation at the beginning, as well as to our global UNICEF C4D indicators that we're always looking at for ensuring that missed children are fully covered, and if there are any reasons for rejection or for refusals according to social reasons, that we can always address. Over.
Thank you. I have a question for in India. Sometimes hard-to-reach campaigns are postponed due to fund constraints, which another stakeholder, it poses risk to to sustain polio-free status. How can we eliminate this? Over to you in India.
Thank you. This is an operational question, and we are aware of such problems. It can happen with any, large organization. That's not desirable. And I think all GPEI partners realize the risk to the program, risk to polio eradication because of this, needless funding delays, and we are all engaged, and we try to settle it on a case-to-case basis, bringing sort of discussing with peers, with colleagues. And so far we have been able to solve problems, not always in time, whether it's with a GPEI partner or within UNICEF or outside UNICEF. So that's the way it goes, and I agree with you that it's certainly not something desirable, but it happens, and we are trying to mitigate this and try to ensure that it doesn't happen in future.
Thank you, in India. I have two questions about C4D in specific for Sahar from Marissa. Is there any emergency funds focus in C4D that could be used fast to respond to an outbreak when government is fragile? And also from Manoj, budget remains a key as we need to carry on C4D before the campaign takes off. What strategy is there to ensure this? Over to you, Sahar.
Okay, on the C4D funds, generally, and you will find in the SOP reference to the no-regret policy. Unfortunately, this is more implemented at WHO, less at UNICEF. However, there is a huge flexibility, and we're trying to ease a lot of the processes financially within UNICEF. So if there is a need to advance immediate funds, that becomes less cumbersome and much more faster if needed. Now, so to answer the question, in terms of the funds are there. How fast we get it to the country, it also depends on the country and regional teams in being able to pull together a solid plan that is very much evidence-based with clear and figures that could be defended as well. So that's the answer to that question. The second point, which is also a very good point with regard to the general C4D funding and campaigning and what can we do if we are supposed to start like before the campaign, that has to do a lot with what we're trying to emphasize on preparedness and pre-positioning of some of the existing activities that we know would need to happen anyway. And just to give a very quick example, if a country in any given context considered a high-risk country, and they don't have any kind of data whatsoever, or very old data on immunization in general, or routine, or on mapping of high-risk areas, or population practices, or refugees, or IDP, general healthcare practices. This is a situation, if you don't have currently an outbreak, to go and investigate that and be able to have additional information or simple analyses that could be done from existing data of MIX or DHS. But if you're hit with an outbreak, and we have to do all of that, in addition to the planning, in addition to the pressure from partners to implement within 14 days and so on and so forth, that becomes much more difficult. So the message here is that we need to try to be as ready, as prepared, as pre-positioning as much activities as possible. If it's PCAs given UNICEF languages that needs to be in place, if community engagement NGOs who need to be contracted and on board, if consultants having some kind of $1 value contracts on a national level to be able to implement or to monitor some of the activities. But if we need LTAs to be activated, some of these things save a lot of time. And by experience, the countries who have this ready were the countries who were able to quickly meet the parameters and hit the ground within 14 days and implement quality campaigns. Over.
Thank you, everybody. We don't have any other questions at the moment, so please feel free. This is your chance to ask directly to both India and Sahar. So if you have some questions, please write them to us now and we'll answer them. Do we have any questions more on the technical aspect from the beginning of the presentation? Any questions about vaccines or the grading, VDPVs, anything like that? And India, do you have a story you want to tell us?
No, thank you. Unless someone has any particular question, I can see for the.
Are there any further questions? If there's no further questions, then we'll wrap up now. Oh, I have one question here. Is there any plan to transition from C4D in polio into routine immunization? That's from Hussein. And India, if you want to answer that one?
This is a little bit of crystal ball gazing, but transition, we should not think of there's a lot of thinking, and there is a separate IMB which is coming up, International Monitoring Board, on the transition policy itself, because the global community has invested a lot in polio resources. This is hugely trained manpower, technical resources, lab equipment, etc., etc. So it would be very constrained to think only that polio resources, C4D or technical resources will directly only go to RI. They can have many uses, and that's all being discussed, worked out, and this is still very much a work in progress. It's a very nascent stage of evolution. Routine immunization is certainly one a natural progression in our minds, because polio is all about immunization, polio eradication, and they have been closely linked. Even without the transition plan, many of our polio staff across the globe have been working in devoting their time for routine immunization. That's a natural corollary or a go-to for polio transition of polio staff, but that is not the only place I think where transition will head to. What exact shape it will become, only the future can tell, and I wouldn't say put a percentage on it, whether it's 30 or 50 or 70% of staff will go to routine immunization or not, because it needs also funding. But that is certainly a way, one of the ways that transition might be headed to. Over.
Thank you very much, Anindya. Do we have any other questions before I give the presenters a final chance to wrap up? If you have your question, please send it now.
Can I just put in one request to all participants?
Yes, please go ahead, Anindya.
Yeah. I would just request all participants, I can't see the last slide now, there were links, or maybe Alex will be sharing with the participants, to please go through the links, both the SOPs, there are C4D related links, there are vaccine management related links, and there are others also. And most of them are on the GPEI website or on Active, so they're downloadable from the internet. Please go through that, and I would encourage to shoot us emails if you have any queries or clarifications perhaps. And there is also an e-learning course on vaccine management, which Jen just reminded me. I should have been talking about it, but I forgot. So please do take that and go through the resources. The point is that the more you do that, the more your thinking gets stimulated, and then you're ready to hit the ground. So that's my request to all the participants. Thank you.
Thank you so much, Anindya. That's very true. I'm going to hand it over to Sahar to say a few words.
First, I want to thank everyone for your time and attendance and giving us the chance to share with you some of the highlights of the SOP. My only last statement is that it does seem that nobody is ever risk-free, and especially as we're trying to completely eradicate the world from polio, there will be always, at the end of the game, a few battles to fight here and there. So we need to be as ready, as prepared, so that we can end the whole thing on time and as planned, as per the strategic game. Thank you.
Wonderful. So to wrap up, I want to thank both Sahar and Anindya and everyone supporting the webinar for their time today. And most importantly, thank you to everyone who participated. We're so happy you could join us. And to those who were not able to participate, we will be recording. This is recorded, and I will share the recording with you through email and through the next newsletter. And as India has pointed out, that last slide has a lot of different resources on it, and that's included in the presentation, which is both audio and visual, so you'll have that as well. And those links are also included in the newsletter. So thank you everybody so much for participating. If you have further questions, you may send them to me, as you all have my email, and I'll try to get the answers for you as soon as possible. Okay, thank you so much. So everyone, you can sign off now, and we look forward to the next webinar, which is on October 6th, which is a Thursday. Thank you so much, and have a good evening.
Thank you. Bye-bye.
Thank you. Bye.